Hi, my name's Natalie. I'm reading this book called The Spirit Catches You and You Fall Down, a Hmong Child, Her American Doctors, and the Collision of Two Cultures by Anne. I'm not even going to try to pronounce that. But basically it's for a class, and there's no free audiobook that I could find on YouTube, so I'm taking one for the team. I'm not doing like the other chapters I already read. You're lost there, I guess, if you haven't read it. So we're just going to start at chapter 6. Who texted me? Oh, nothing. Okay. Chapter 6, High Velocity Transcordial Lead Therapy. It was said in the refugee camps in Thailand that the Hmong in America could not find work, were forbidden to practice their religion, and were robbed and beaten by gangs. It was also said that Hmong women were forced into slavery, forced to have sex with American men, and forced to have sex with animals. Dinosaurs lived in America, as well as ghosts, ogres, and giants. With all this to worry about, why did the 1,500 Hmong who gathered at the Ban Vinai soccer field, if I mispronounce things, don't tell me. I don't want to know. We'll get you a better angle. Where was I? Soccer field, to voice their deepest fears about life in the United States, choose to fixate on the doctors. A year after I first read the account of that gathering, and as I was attempting to deal out a teetering pile of notes, clippings, and photocopied pages from books and dissertations into several drawerfuls of file folders, I had a glimmering of insight. There were hundreds of pages whose proper home I was at a loss to determine. Should they go in the medicine folder, the mental health folder, the ominism folder, the shamanism folder, the social structure folder, the body-mind-soul continuum folder? I hovered uncertainly, pages in hand, and realized that I was suspended in a large bowl of fish soup. Medicine was religion. Religion was society. Society was medicine. Even economies were mixed up in there somewhere. You had to have or borrow enough money to buy a pig or even a cow in case someone got sick and a sacrifice was required. And so was music. If you didn't have a quiche player at your funeral, your soul wouldn't be guided on its posthumous travels, and it couldn't be reborn. And it posthumous travels, and it couldn't be reborn, and it might make your relatives sick. In fact, the Hmong view of health care seemed to me to be precisely the opposite of the prevailing American ones, in which the practice of medicine has fissioned into smaller and smaller subspecialties, with less and less truck between bailiwicks. The Hmong carried holism to its ultima thule. As my web of cross references grew more and more thickly interlaced, I concluded that the Hmong preoccupation with the medical issues was nothing less than a preoccupation with life and death and life after death. Not realizing when a man named Zhong or Li or Mo walked into the family practice center with a stomach ache, he was actually complaining that the entire universe was out of balance. The young doctors of Merced frequently failed to satisfy their Hmong patients. How could they succeed? They could hardly be expected, as Dwight Conquergood had done at Ban Vinai, to launch a parade of tigers and dabs through the corridors of MCMC. They could hardly be expected to respect their patients' systems of health beliefs, if indeed they ever had the time and the interpreters to find out what it was, since the medical schools they had attended had never informed them that diseases are caused by fugitive souls and cured by jugulated chickens. All of them had spent hundreds of hours dissecting cadavers and could distinguish at a glance between the ligament of the Hasselbach and the ligament of the traits. But none of them had a single hour of instruction in cross-cultural medicine. To most of them, the Hmong taboos against blood tests, spinal taps, surgery, anesthesia, and autopsies, the basic tools of modern medicine, seemed like self-defeating ignorance. They had no way of knowing that a Hmong might regard these taboos as the sacred guardian of his identity, indeed, quite literally of his very soul. What the doctors viewed as clinically efficiency, the Hmong viewed as frosty arrogance. And no matter what the doctors did, even if it never transpired on taboo territory, the Hmong frighted? As they were the negative... Oh, no. Why did I do this? Okay. Freighted as they were, the negative expectations accumulated before they came to America, inevitably interpreted in the worst possible light. Whenever I talked to Hmong people in Merced, I asked them what they thought the medical care they and their friends had received. The doctors at MCC are young and new. They do what they want to do. Doctors want to look inside the woman's body. The woman very pain, very hurt, but the doctor just want to practice on her. One lady, she is cry, cry, cry. She do not want doctor to see her body. But this country, there is the rule. If you want to stay here, you must let doctor examine the body. Most old people prefer not to go to doctor. They feel maybe doctor just want to study me, not help my problems. They scary this. If they go one time, if they not follow appointment and do like doctor want, doctor get mad. Doctor is like earth and sky. He think you are a refugee. You know nothing. It took us an hour to see the doctor. Other people who are rich, they treat them really well, and they do not wait. This lady, she had some blisters inside her mouth, and the doctor, he say, you need surgical treatment. She say, no, I just need medication for pain only. He say, I know more than you do. He completely ignore what she ask. My half-brother, his body was swollen and itchy, and the doctor say, hey, you got a cancer, and we need to operate. He agreed to sign the operation, but then he didn't want to do it. But he say to me, I already signed everything, and the doctor going to send me to jail if I change my mind. Hmong should never sign anything at MCC. MCC? What? MCMC. The student doctors just want to experiment MCC. Experiment on the poor people, and they kill the poor people. The doctor is very busy. He takes people that are sick, he produces people that are healthy. If he do not produce, his economic will be deficit. But the Hmong, he will want the doctor to calmly explain and comfort him. That does not happen. I do not blame the doctor. It is the system in America. All of the people quoted here speak English and thus belong to the more educated and most Americanized segment of Hmong society in Merced, the segment most likely to understand and value Western medical care. Nonetheless, their version of reality fails to match that of their doctors pretty much across the board. From the doctor's point of view, the facts are as follows. MCMC is indeed a teaching hospital, but this works to its patients' advantage since it has attracted skilled faculty members who must constantly update their knowledge and techniques. The young residents are all MDs, not students. The Hmong spend a long time in the waiting area, but so does everyone else. Patients who change their mind about the surgery do not go to jail. The doctors do not experiment on their patients, neither do they kill them, though their patients do sometimes die, and are more likely to do so if, like the Hmong, they view the hospital as a dreaded last resort to be hazarded only when all else fails. Although the doctors at MCMC are not aware of most of the Hmong's specific criticisms, they would be unlikely to ask, and the Hmong would be unlikely to answer. They certainly know the Hmong do not like them, and that rankles. What? The residents may be exhausted, since their shifts are up to 24 hours long, and until recent years were up to 33 hours long. They may be rushed, since many clinic appointments are only 15 minutes long, but they are not, and they know they are not, greedy or spiteful. Most of them have chosen the field of family practice, which is the lowest paying of all medical specialties, for altruistic reasons. Of course, some of the subspecialties would say we went into family medicine because we aren't smart enough to be urologists or ophthalmologists. Bill Selvage, MCMC's former chief resident, told me, if we were urologists, we'd make a lot more money, and we wouldn't have to get up so often in the middle of the night. Bill is an old college friend of mine. It was he who first told me that the hemong of Merced, whom he described as being such challenging patients that some of his fellow doctors suggested the preferred method of treatment for them was high-velocity transcordial lead therapy. When I asked Bill what that meant, he explained the patient should be shot in the head. That's crazy. Hold on. Sorry, if I stop randomly, it's because I'm adding a sticky note to something that I want to remember. You'll just have to put up with it. I'm sorry. Where was that? Okay. I'll fix that later. Bill himself did not seem to find the hemong quite as exasperating as some of his colleagues did. Perhaps because of the lessons in cultural relativism he had learned during the 2 years he had spent with the Peace Corps in Micronesia. And perhaps because, as he pointed out to me, hemong acted no stranger than his next-door neighbors in Merced, a family of white fundamentalist Christians who had smashed their television set and then danced a jig around it. The neighbors' children had then offered to smash Bill's set as well. He had politely declined. Bill was the sort of person I'd always wanted to have as a doctor myself, and before I came to Merced, I found it hard to believe that his hemong patients weren't prostrate with gratitude. It's a funny word. When refugees from Laos started settling in Merced County in the early 1980s, none of the doctors at MCMC had ever heard the word hemong, and they had no idea what to make of their new patients. They wore strange clothes, often children's clothes, which were approximately the right size, according to the local Goodwill. When they undressed for an examination, the women were sometimes wearing jockey shorts, and the men were sometimes wearing bikini underpants with little pink butterflies. They wore amulets around their necks and cotton strings around their wrists. The sicker the patient, the more numerous the strings. The sticker. They smelled of camphor, mentholatum, tiger balm, and herbs. When they were admitted to the hospital, they bought their own food and medicines. The parents of one of Neil Ernst's patients, a small boy with a gastrointestinal disorder, once emptied his intravenous bottle and replaced its contents with what Neil described as green slime, an herbal home brew whose ingredients the doctor never determined. Hemong patients made a lot of noise. Sometimes they wanted to slaughter live animals in the hospital. Tom Silt, a former MCMC resident, recalled they'd bang the crap out of some kind of musical instrument, and the American patients would complain. Finally, we had to talk to them. No gongs and no dead chickens. Neil Ernst and Peggy Phillip were shocked to discover quarter-sized round lesions, some reddish and some hypopigmented, on the abdomens and arms of some of their pediatric patients. They looked like burns. Some of the lesions had healed and others were still crusty, suggesting that the skin had been traumatized on more than one occasion. Neil and Peggy immediately called Child Protective Services office to report that they had identified several cases of child abuse. Before the cases were prosecuted, they learned from a San Francisco doctor that the lesions were the result of dermal treatments, rubbing the skin with coins or igniting alcohol-soaked cotton under a tiny cup to create a vacuum, that were common among several Asian ethnic groups and that were traditional healing art, not a form of abuse. I once attended a conference on Southeast Asian healthcare issues at which a prominent doctor showed me some slides of coin-rubbing lesions and told the audience, "It doesn't hurt." The young Lao woman sitting next to me whispered, "Yes, it does." Dan Murphy remembers that when he was a resident, he heard a story about a hemong father in Fresno who was sent to jail after black marks were discovered on his child's chest by an elementary school teacher. The father hanged himself in his cell. The story is probably apocryphal, though it is still in a wide circulation. But Dan and the other doctors believed it, and they were shaken to realize how high the stakes could be if they made a tactical error in dealing with the hemong. And there were so many ways to err. When doctors conferred with a Hmong family, it was tempting to address them reassuringly, Americanized teenage girls who wore lipstick and spoke English, rather than the old man who squatted silently in the corner. Oh. Okay, never mind. Yet failing to work with the traditional Hmong hierarchy, in which males ranked higher than females and old people higher than young ones, not only insulted the entire family but also yielded confused results, since the crucial question had not been directed towards those who had the power to make decisions. Doctors could also appear disrespectful if they tried to maintain friendly eye contact, which was considered invasive, touch the head of an adult without permission, grossly insulting, or beckon with a crooked finger, appropriate only for animals. And doctors could lose the respect of their patients if they didn't act like authority figures. The young residents at MCMC did not enhance their status by their propensities for introducing themselves by their first name, wearing blue jeans under their white coats, and carrying their medical charts in little backpacks, and drinking their coffee from Tommy Tippy cups. What is that? Doctors could get into trouble if they failed to take the Hmong religious beliefs into account. For example, it was important never to compliment a baby's beauty out loud, lest a dab over here and be unable to resist snatching its soul. Similarly, when a 70-year-old Hmong patient once asked if her failure to get pregnant might be attributed to the dad who frequently visited her in her dreams, sometimes sitting on the edge of her bed and sometimes having sexual intercourse with her. It was fortunate that the resident on duty in OB/GYN clinic listened with calm attention instead of diagnosing an acute psychosis and dispatching her to a locked ward. On the other hand, bending over backwards to be culturally sensitive did not always work. Bill Selvage once examined a depressed middle-aged Hmong woman with severe headaches, surmising that some of her problems stemmed from cultural dislocation and that her spirits might be buoyed by traditional treatment. He recommended that she see a Twix nape. However, as reported in his clinic notes, she is reluctant to go to a shaman, partly because she is now Catholic and partly because she takes too many chickens and or pig that have to be killed in her home for her to satisfy shaman and traditional healers. She may have tried this in the past because she indicates a previous landlord told her to leave home after police were called when some members of her family were about to sacrifice a pig. Disappointed, Bill prescribed aspirin. Compared to the other patients that frequented Merced Community Medical Center, the Hmong were not only trickier but sicker. They had high incidence of high blood pressure, anemia, diabetes, hepatitis B, tuberculosis, intestinal parasites, respiratory infections, and tooth decay. Some of them had injuries or illnesses they had acquired during the war in Laos or its aftermath. Gunshot wounds, chronic shoulder pain from carrying M16 rifles, deafness from exploding artillery shells. "And how long have you had these headaches?" asked one bored doctor. His Hmong patient replied matter-of-factly, "Ever since I got shot in the head." Another doctor wondered if a Hmong patient... picking the wrong one. If a Hmong patient's usual neuropathies might have been caused by nutritional deficiencies, learned that when fleeing to Thailand, the men had spent several months living in the jungle, subsisting largely on insects. Before receiving clearance to be admitted to the United States, all Hmong, like other refugees, undergo medical screening by physicians employed by the International Organization for Migration. The physicians must sign forms indicating that they have specifically examined the visa applicant for and found them free of 8 contagious diseases: leprosy, tuberculosis, 5 venereal diseases, and since 1987, positive antibodies for HIV, and 8 mental conditions including sexual deviation, psychopathic personality, and previous occurrences of 1 or more attacks of insanity. Paul DeLay, the former director of the refugee clinic at San Francisco General Hospital, explained to me, "You get the impression that these problems are being carefully screened for back in Thailand. In fact, the exams are approximately 10 seconds long. All you get is a blood test for syphilis and HIV, a quick skin check for leprosy, and a chest x-ray for TB. Early on, you could buy a clear x-ray on the black market." In 1981, it got a little harder because the immigration officials started stapling a photo of the person to the x-ray, but it was still possible, and despite what it says in the form, there is absolutely no screening for mental conditions. In the early days, some medical professionals would walk down the aisle of the airplane, and if someone looked psychotic, they'd be thrown off. So if a family was worried about their crazy relatives, they just load him up with opium so he'd fall asleep. DeLay pointed out that although few refugees are rejected for medical reasons, it is a terrible crisis for the ill person's family when this does happen, especially because once an applicant is medically excluded by one potential country of asylum, he is unlikely to be accepted anywhere else. All of this means that the refugees have one more reason to be afraid of doctors, said DeLay. My neck hurts. Once a refugee arrives, is this a recording? It is. In the United States, post-immigration screening is not legally required. So although most states have refugee health programs, many Hmong chose to not be screened and thus encountered the medical system for the first time during an emergency. In Merced, new arrivals are voluntarily processed through the county's medical health department, which checks primarily for tuberculosis and intestinal parasites. Though funding is too meager to allow more than a cursory examination during which the patient undresses only from the waist up, refugees who are pregnant or who have glaringly evident medical problems are referred to the hospital or clinic. Merced's health department is also responsible, according to its former director, Richard Welch, for dealing with the problems no one else in the community wants to get their hands dirty dealing with. For example, when a rumor circulated that in Merced that a Hmong family was raising rats to eat, a public health worker paid a call. One of the children in the family had diarrhea, so the question was, did the rats have salmonella or shigella? Is that how you say that? Recalled Karen Olmos, a nurse in the health department's communicable disease program. I told the worker, for God's sake, do not just barge in and tell them you want to see the rats. So she went over there and on some other pretext, and there were the rat cages. She could see the rats were from the pet store, not the gutter. They were big whoppers. Instead of making the family feel bad about the rats, she simply suggested that they raise rabbits instead. Low startup cost, high yield, high protein. On another occasion, the health department launched an investigation after 60 Hmong with diarrhea arrived at MCMC emergency room. It turned out that for a major feast on a hot summer day, a pig infected with salmonella had been butchered, ripened in the sun for 6 hours, and served in various forms, including ground raw pork mixed with raw blood. Although by the mid-'80s, the regular staffs of the health department and the hospital had become inured, is that how you say that? If not resigned to dealing with the Hmong, each year brought a fresh crop of family practice residents who had to start from scratch, avid for exotic medical experience and hoping that with its large refugee population, Merced might be sort of like the Peace Corps, but with good hamburgers. And these new arrivals were deeply disappointed to find that their Hmong patients spent most of their time staring at the floor and speaking in monosyllables, of which the most frequent was yes, and after they began to realize that yes simply meant that the patients were potentially listening, not that they agreed with or even had any idea that what the doctor was talking about, it was typically Hmong for patients to appear passively obedient, thus protecting their own dignity by concealing their ignorance and their doctor's dignity by acting deferential. And then, as some of them, as soon as they left the hospital, to ignore everything to which they had supposedly assented. When no interpreter was present, the doctor and the patient stumbled around together in a dense fog of misunderstanding whose hazards only increased if the patient spoke a little English, enough to lull the doctor into mistakenly believing some useful information had been transferred. When an interpreter was present, the duration of every diagnostic interview automatically doubled, or tripled, or centupled, because most medical terms had no Hmong equivalents. Laborious paraphrases were often necessary. In a recent publishing Hmong English medical glossary, the recommended Hmong translation for parasite is 24 words long, for hormone 31 words, and for X chromosome 46 words. The prospect of those tortoise-paced interviews struck fear into the heart of every chronically harried resident, and even on the rare occasions when there was a perfect verbatim translation, there was no guarantee that either side was actually understood the other. According to Dave Schneider, who served his residency in Merced in the late 80s, the language barrier was the most obvious problem, but not the most important. The biggest problem was the cultural barrier. There is a tremendous difference between dealing with the Hmong and dealing with anyone else, an infinite difference, Dan Murphy said. The Hmong simply didn't have the same concepts that I did. For instance, you can tell them that someone is diabetic because their pancreas doesn't work. They don't have the word for pancreas. They don't have an idea for pancreas. Most of them have no concept that the organs they saw in animals were the same as in humans, because they didn't open people up when they died. They buried them intact. They knew there was a heart because they could feel the heartbeat, but beyond that, well, even lungs were kind of a difficult thing to get into. How would you intuit the existence of lungs if you had never seen them? Hmong patients might not understand the doctor's diagnoses, but if they had summoned the courage to visit the clinic, they wanted to be told that something was wrong and to be given something, preferably a fast-acting antibiotic, to fix it. The doctors had a hard time meeting these expectations when the Hmong complained, as they frequently did, of vague chronic pain. At a particular series of diagnostic questions I usually ask when a patient complains of pain, said Dan Schneider. I ask what makes it better and what makes it worse. Is it sharp, dull, piercing, tearing, stinging, aching? Does it radiate from one place to another? Can you rate it severity on a scale from 1 to 10? Is it sudden? Is it intermittent? When did it start? How long does it last? I would try to get an interpreter to ask a Hmong patient these questions, and the interpreter would shrug and say, he just says it hurts. It has been well known since the aftermath of the Second World War that because of the enormous psychological traumas they have suffered, refugees of all nationalities have an unusual high incidence of somatization, in which emotional problems express themselves as physical problems. After dozens of gastrointestinal series, I'm skipping it. Blood tests and CT scans, the Merced doctors began to realize that many Hmong complaints had no organic basis, though the pain was perfectly real because so little could be done for them and because they were so depressing to be around. Hmong with total body pain were among the clinic's least popular patients. I once heard a resident tried to persuade a physician assistant to take over one of his cases. No, Steve, said the assistant. No, I do not want to see an elderly Hmong woman with multiple complaints and depression. I will take your coughs and your back problems, but don't give me one of those. In order to show they were taking the complaint seriously, some doctors prescribed that they call the Hmong cocktail: Mortin, an anti-inflammatory, Elavil, an antidepressant, and vitamin B12. Oh, terrible. But the patients did not usually get better. For the underlying problems, explained Belle Selvage, there was no treatment that was in my power to offer. If Hmong patients left the family practice clinic without a prescription, for example, if they had cold or flu, they sometimes felt cheated and wonder if they were being discriminated against. But if they were given a prescription, no one knew if it would be followed. You'd say, take a tablespoon of that, said Mary Marcus, a nurse at the clinic. They'd say, what's a tablespoon? One patient refused to swallow a pill because it was an inauspicious color. Long-term therapy, for example, the doses of that must be taken every day for a year to treat tuberculosis was always problematic, especially if the illness was asymptomatic. Whatever the prescription, the instructions on pill bottles were interpreted not as orders but as malleable suggestions. Afraid that medicines designed for large Americans were too strong for them, some Hmong cut the dosage in half, others double dose so they could get well faster. It was always frightening for the doctors to prescribe potentially dangerous medications, lest they be misused. In one notorious case, the parents of a large Hmong family en route from Thailand to Hawaii were given a bottle of motion sickness pills before they boarded the plane. They unintentionally overdosed all of their children. The older ones merely slept, but by the time the plane landed, the infant was dead. The medical examiner elected to withhold the cause of death from the parents, fearing they would be saddled with an impossible burden of guilt if they learned the truth. When a Hmong patient required hospitalization, MCMC nurses administered the medications, and the doctors could stop wondering whether the dose was going to be too high or too low. There was plenty else to worry about. When they walked into a hospital room, they often had to run a gauntlet of a dozen or more relatives. Decisions, especially about procedures such as surgery that violated Hmong taboos, often took hours. Wives had to ask their husbands had to ask their elder brothers had to ask their clan leaders, and sometimes the clan leader had to telephone even more important leaders in other states. In emergency situations, the doctors sometimes feared their patient would die before permission could be obtained for life-saving procedures. All too often, permission was refused. They won't do something just because somebody more powerful says do it, said Dan Murphy. They will sit back and watch and sort of mentally chew it over. And then they may or may not do it. That attitude has been very culturally adaptive for the Hmong for thousands of years. And I think that it is culturally adaptive, but when it hits the medical community, it was awful. I've been reading for like 30 minutes. Teresa Callahan once saw a patient in the emergency room who had an ectopic pregnancy that required the immediate removal of a fallopian tube. I told her over and over again that if the tube ruptured at home, she might die before she get to the hospital. I called her husband and her mother and her father and her grandparents, and they all said nope. All that mattered to them was that she would have one less tube and she might not be able to have kids after that. And when they heard that, it was no. She'd rather die. I had to watch her walk out of the door knowing she had something that could kill her. Several days later, the woman consented to the surgery after consulting a Thai doctor in Fresno. Teresa does not know how he persuaded her. Another Hmong woman, examined shortly before she went into labor, was told that because her baby was in a breech position, a cesarean section was indicated. Although breech births in Laos often meant death to both mother and child, the woman attempted to give birth at home rather than submit to the surgery. The attempt failed. Dave Schneider was on call when an ambulance brought her to the hospital. I got paged at 3 or 4 a.m., he recalled. Dr. Schneider sat to the emergency room. There's a lady coming in with a breech baby that won't come out. The paramedics came in wheeling this Hmong woman on a gurney. She was making no noise, just moving her head around in panic. There was a blanket partly over her. She had a very clear visual memory of lifting. I have a very clear visual memory of lifting the covers to reveal a pair of little blue legs not moving, hanging out of her vagina. Dave delivered the baby vaginally by manually stretching the cervix over its head. The mother recovered, but the baby died of oxygen deprivation. Most Hmong women don't go to the hospital to give birth, erroneously believing that babies born at home would not become U.S. citizens. Doctors were more likely to encounter them on the labor and delivery floor than in any other medical context because they had so many children. In the mid-'80s, the fertility rate of Hmong women in America was 9.5 children, which according to one study was at the upper limits of human reproductive capacity, second only to the Hutterites. The fertility of white Americans is 1.9 children, and of black Americans, 2.2. The rate has undoubtedly decreased, though it has not been recently quantified as young Hmong have become more Americanized, but it's still extraordinarily high. The large size of Hmong families is the inevitable result of two circumstances. Hmong women usually marry during their teens, sometimes as early as 13 or 14, thus allowing their reproductive years to extend nearly from menarche to menopause. Is that how you say? Okay. And as a rule, they are highly suspicious of contraception. In 1987, when Donald Renard, a researcher on refugee issues at the Center of Applied Linguistics in Washington, D.C., visited Ban Vinai, he learned that in an effort to curb exploding birth rates at the camp's inhabitants, an administrator had promised free cassette recorders to women who volunteered to take contraceptive pills. Many women accepted both tape recorder and the pills, but they soon discovered a marvelous paradox. The contraceptives, which they had probably never intended to swallow in the first place, were a superior fertilizer. So the pills ended up being ground up and sprinkled on Hmong vegetable plots while the gardeners continued to get pregnant. Damn. The Hmong have many reasons for prizing fecundity. I don't know what that means. The most important is that they love children. Fecundity. Is that how you say that? I don't know how to say that. The most important is that they love children. In addition, they traditionally value large families because many children were needed to till the fields in Laos and to perform certain religious rites, especially funerals. And because the children mortality rate in Laos was so high, because so many Hmong died during the war and its aftermath, and because many Hmong still hope that their people will someday return to Laos and defeat the communist regime. In the refugee camps, Hmong newborns were often referred to as soldiers and nurses. The frequent appearance at MCMC of Hmong women on the Merced public assistance roles who were about to give birth to their 8th, 10th, or 14th child did not endear them to those staff members who have strong ideas about family planning. I am totally disgusted by the breeding rate, said Robert Small, an obstetrician who is well known for his clinical proficiency, his unapologetic contempt for the Hmong, and his propensity for mixed metaphors. The Hmong breed like flies, as if the golden goose of welfare will continue to lay eggs forever. According to Dr. Small, the Hmong are highly uncooperative obstetrical patients. They do not do a damn thing you tell them, he said. They just come in late and drop it out. In fact, they wouldn't come at all if they didn't need to get the birth certificate so they could get more welfare. You or I, we can conceive to the degree of ignorance. Oh, you or I, we can't conceive to the degree of ignorance. They're almost a Stone Age people. Hell, they never went to a doctor before. They just had a baby in the camp or the mountains or whatever the hell they came from. Because they were approximately as fond of most doctors as Robert Small was of them, among women who arrived at Merced in the refugee influx of the early and mid-'80s tended to avoid prenatal care. Then there's something at the bottom of the page. Most Hmong women, though more Americanized now, still avoid prenatal care until at least their second trimester of their pregnancies. Several studies suggest that their pregnancies usually have good outcomes nonetheless, with babies delivered at term, at normal weight, and without complications. Several cultural factors, low rates of drinking and smoking, nutritious diets, work in their favor. In addition, as obstetrician Raquel Arias explained to me, Hmong women have proven pelvis. If you had an inadequate pelvis, okay, I don't know how to say the plural of that. If you had an inadequate pelvis back in Laos, it was lost to evolution. There was no one available to do a C-section for disproportion, so those women died, and their pelvises, I don't know, died with them. Also, Hmong don't marry Swedes. They marry people who are genetically similar to them, so they are likely to have babies that are the right size for their body. And then back to where we left off. They were particularly frightened of pelvic exams performed by male doctors. In the Hmong healing system, Twix Neebs and herbalists who do not touch their patients may treat people of the opposite sex. But in the more intimate sphere of dermal therapy, massage, acupuncture, pinching, coin rubbing, men usually treat men and women. Once they were in labor, the women preferred to wait until the last minute to arrive at the hospital. They often gave birth in the parking lot, the emergency room, or the elevator. Wheelchairs at MCMC were called Hmong birthing chairs because so many Hmong babies were born in them en route to the labor and delivery floor. Even if they got to the hospital on time, the woman made so little noise during labor that the hospital staff, not realizing birth was imminent, often failed to transfer them from labor beds to delivery tables. A few doctors found this forbearance admirable. We were told in medical school that childbearing is one of the 3 or 4 most painful things that can happen to a person, said Dave Schneider. Most women scream. Hmong women don't make any sound at all. They are just remarkably, unbelievably stoic. The obstetric nurses were less impressed by the silence of their Hmong patients. Dan Murphy explained, the nurses' attitude was more, why didn't they tell us they were about to deliver? What, are they stupid? I think that was kind of displaced anxiety. I don't think that they were angry at the Hmong so much as they were anxious because the Hmong didn't fit the pattern they had been trained to deal with. Some other ways in which Hmong women failed to fit the pattern included squatting during delivery and refusing permission for episiotomy incisions to enlarge the vaginal opening. Although Leah's mother, when she lived in Laos, had preferred to go through labor alone, many Hmong women were used to being held from behind by their husbands who massaged their bellies with saliva and hummed loudly just before the baby emerged. The husband made it very clear that they expected from the doctors. One father slapped my hand when I was controlling the progress of the baby's head, recalled Chris Hartwig. The nurse got very upset because he violated the sterile field. Then, as I was clamping the umbilical cord, he reached down and touched the cord and said, "This is how long it has to be." Because neither of the father's demands endangered the health of the mother or the child, Chris Hartwig complied. But what if a patient or her husband or father or brother, who was more likely to make the decision, refused an episiotomy that her doctors believed would prevent an imminent 4th-degree laceration, a laceration that the husband or father or brother might then forbid the doctor to stitch up? Or worse, what if the fetal monitor indicated that the baby's heartbeat had dangerously decelerated, and the family were used to sign the consent form for an emergency cesarean section? As Raquel Arias, by common consent, the MCMC obstetrician with the most dazzling combination of skills and empathy, what she did when the wishes of her Hmong patients conflicted with the standard of medical care she was accustomed to providing. "I have the same standard of care for the Hmong as I have for everyone else," she said. "My hands are just tied to provide it, so I give them suboptimal care. Sometimes you can find middle ground and try to understand where they're coming from, which is hard, but not impossible. Sometimes you can persuade them to do what you want. You keep telling them stuff, and if you want it bad enough, maybe it'll work. It is when the well-being of the fetus is in jeopardy, a fetus that in our perspective is a full person who should have the rights and privileges that all citizens of this country have, and the beliefs and customs of the family seem to be going against what you believe in, is in the fetus's best interest that you have the worst conflict. When that happens, it is an unbelievably terrible situation to be in. It is awful. It is not the kind of tension you feel when you get mad at someone from your own background who is doing something they know is bad, like smoking or drinking when they are pregnant. This is a different kind of tension because they don't know that what they are doing is something bad. According to their beliefs and principles, they are trying to protect the mother and the baby and their way of life. And when you think is necessary happens to be exactly the opposite of what they think is appropriate. Hold on. Oh, thank goodness. Listening to Raquel, I was struck, as I often was, by the staggering toll of stress that the Hmong exacted from the people who took care of them, particularly the ones who were young, idealistic, and meticulous. During Hmong labors that were going badly, Raquel bit her fingernails, which were impeccably polished with purple passion enamel, to the quick. Suki Waller, Suki Waller of, oh my god, that's embarrassing. Okay, a psychologist at Merced Community Outreach Services, who was highly regarded in local Hmong circles, went through a period of throwing up before going into work each morning. Benny Douglas, a resident who was known for his imperturbable calm, he was so upset by one problematic case. An elderly Hmong woman had gastric cancer, and Benny hadn't been able to persuade her sons to consent to her surgery, that he developed severe insomnia. I remember seeing Benny slumped forlornly in a chair, alone in residents' call rooms at dusk, dictating his notes about Mrs. Thou in a little tape recorder, while he drank cup after Tommy Tippy cup of coffee and reflexively picked at his eyelashes. I got something in my throat. When I asked Dan Murphy why he thought caring for Hmong caused so much stress, he said people in the early years of their medical careers have invested an incredible amount of time and energy and pain in their training, and they have been taught that what they learned in medical school is the only legitimate way to approach health problems. I think that is why some young doctors go through the roof when Hmong patients reject what we have to offer them, because it intimates what Western medicine has to offer is not much. The only doctor I met in Merced who seemed untroubled either by his encounters with the Hmong or by the question of whether he was providing optimal care was Roger Fife, a family physician who served his residency at MCMC in the early 80s and then joined the staff of a local private hospital. Dr. Fife estimated that 70% of his clientele was Hmong, a fraction unequaled in any other practice in town. When I asked him why he was so popular, he was able to offer no explanation other than maybe I talk slower than the other doctors. His patients have no problem explaining. Every Hmong I asked said exactly the same thing. Dr. Fife doesn't cut. On the whole, that was true. Dr. Fife generally did not perform episiotomies on Hmong women, though he did not know why they didn't want them, never having asked. He avoided cesarean sections whenever possible, and he had particularly endeared himself to his Hmong patients by handing them their babies' placentas in plastic bags whenever they requested them. Though he had no idea what they did with them and said he had never been curious, Roger Fife is not held in high esteem at MCMC. He's a little thick, one of the residents told me. He's not the most intelligent graduate our program has ever had, said another. He's an adequate physician, said a third, choosing his words carefully, though I doubt that even the most ecumenical of Merced's doctors would wish to have more Hmong patients. Still, it must have been galling for these residents to realize that the Hmong community overwhelmingly preferred a doctor whose standard of care they believed to be inferior to their own. Roger Fife happened to espouse a philosophy that carried more weight than the Hmong than any degree of knowledge, intelligence, or technical skill. When I asked him why he didn't usually force his Hmong patients to comply with conventional American medical practices, he shrugged and said, "It's their body." And that's the end of chapter 6. Thank God. I've been talking for like 50 minutes straight. My throat is dry. I also just realized that the quality of my MacBook camera is dismal. Okay. Well, I hope this helped. It probably didn't, because I actually couldn't pronounce most of the words in here. which is super embarrassing. But yeah, I'll probably keep doing this just because it makes me read the book. And I don't usually read the book. So, I don't know, I'll keep posting them to the canvas or whatever. Okay, bye!